right. So, this is just a brief introduction. Joe and I are going to be taking over a portion of the podcast because Buzz and Daniela have been out and about traveling the country slash world. And our goal is to give you a little bit more of an in-depth view of some of the topics they've been speaking on. So giving you a little bit more science, a little bit more research, and a little bit more clinical experience. We are the staff that are in the Grove City location. A little bit of background. I am the operations manager as well as the compliance officer. So I've done a lot of the research end for quite a while now, spending time just Buzz saying, let's do this. And then me going, all right, I'll figure it out.
Yep.
And then Joe is the clinic director there. A little bit of background on you.
Yep. So my name is Joseph Matovich. I am the director for anti-aging and aesthetics, which oversees hormone replacement therapy, functional medicine, medically assisted weight loss, aesthetics, NAD, peptide therapies, and things like that. I've been with the company for almost 7 years now, in this field of medicine for almost about 15. Yeah.
And we're going to make it interesting.
Yep. So we'll go more into the deep dive of how the topics on this podcast are applicable in the clinical setting, and maybe use some examples of case management we've experienced ourselves, working hands-on with the patient. And maybe we'll hit something that will feel relatable to something that you've dealt with yourself.
All right. Coming from the Great White North of Columbus, Ohio, where it's been snowing. Today we're talking a little bit about PMDD, the clinical definition, as well as applicable things that we've seen in the office. First thing that we would want to mention is definition of PMDD.
Yeah. So PMDD stands for Premenstrual Dysphoric Disorder, and it's starting to get more popular and talked about now. I think we're seeing it diagnosed more frequently. I think it's something we're starting to see somewhat more prevalently in the office as far as a practice setting. Um, but we like to be clear, PMDD and PMS are not quantifiably the same thing. They're not the same diagnosis. And I think for a long time, they really got treated the same way. So, if we wanted to kind of define the two or separate the two, right?
Yeah, let's start with PMS.
Yeah. So PMS, most patients are going to be familiar with premenstrual symptoms, and that may be identifying, the physical characteristics, right? The bloating, the cramping, the discomfort. And certainly there is a mood component or a subjective symptom that goes with it as well. Volatility in moods, changes in sense of well-being, agitation, and things like that.
Everybody jokes about how all of a sudden their husband chewing it drives them up a wall, anywhere between 8 to 3 days before they start their period.
Yep.
That PMS.
Yeah. So that's PMS. And I think, and Tiffany, you may have a different experience. I think for a long time, and the reason that the, kind of the differentiation between PMS and PMDD is so important is what we're finding out now is a lot of these PMDD cases are patients that have been inappropriately diagnosed with PMS. And then some of the traditional PMS interventions have been not only not helpful, but actually deleterious as far as an outcome standpoint. So
I think we have to acknowledge also that PMDD does have a mental health component, which I feel like has been more researched here recently. So there's a little bit more of the psychiatric end of it that you're seeing.
Yeah, and I think the PMDD, that would be, probably where the biggest differentiation between PMS comes in. It is a mood, it is a psychological disorder, but it's really extreme, right? So for example, this isn't I'm agitated or I'm irritable. This is I'm irrationally mad.
I think they
Uh,
qualify it as rage.
yes, rage. I'm having suicidal ideation 1 to 2 weeks out of the month.
Incredible depression, like can't pull yourself out of bed, can't think straight, can't do anything.
Yeah, we've had patients who say, 10 days out of the month, I'm ready to divorce my husband and our family falls apart. And the other 20 days, we're perfectly in love. So it's really about the magnitude and the severity and kind of the volatility of the mental component that comes with it that would differentiate PMDD from like a traditional PMS patient.
Correct. So it's the acknowledgement that your brain is responding to hormones that are happening,
Right.
not just necessarily the hormone component of it.
Right. So, because all the hormones are neurochemically active, um, but we're seeing there's more to PMDD than just transient fluctuations in hormones. Correct.
Yeah, definitely. I mean, patient experience specifically, like we have one of them's our friend actually, and we can tell literally day 18. We know it's coming. All hell will break loose
Yeah.
that day, starting that day, and then it'll be totally fine as soon as period starts. Like everything will be back to normal. Love, hugs, and kisses.
Yeah. Yeah. We always joke that if we had an office dog, or it would
A mood sensing dog.
a mood sensing dog, it would hide under a chair like a thunderstorm was coming. Um, so I think there's valuable to talk about, what the hormones do neurochemically and what we may see with PMS, and then get into kind of differentiating how is PMDD different and how even management may be different.
Yeah, and talking about the more traditional form of management that we've seen coming
Right.
into this, and then what we've seen that it actually is beneficial going forward.
Right. So, you know, when we look at PMS, I'd say what really stems that. The hormones are really all over the place throughout the course of the month anyway.
I mean, there's a routine to it,
Yeah.
but yes,
Yeah,
up
yeah.
and down and all over the place.
Right. So, testosterone being the relative one constant with the exception of a mid-cycle or ovulatory spike, but it doesn't have really anything to do with regulating the endometrium. So it doesn't need to change a whole lot. Estrogen generally is going to have several different transient climbs. It's going to spike preceding ovulation. It's going to fall abruptly thereafter, and then climb again through luteal phase, and then drop off again before menses. Um, Progesterone is generally lower in the front half of the cycle. Um, Climbs predominantly hits its peak at mid luteal phase after ovulation because most of it's made by the corpus luteum, and then falls very abruptly before the onset of menses, and that's what causes sloughing off the endometrium. So,
And really symptoms can be
Mhm.
experienced from the hormones themselves and or from the ratios of the hormones, the relationship of that time of the month. So the peaks and the troughs, because you can even experience testosterone differently when your estrogen is lower.
yeah, and that's we really like. We have a lot of patients come in with PMS and say, "Well, I had my hormone levels checked by my doctor, and they said everything looked fine." And where that can be subtle and nuanced in interpretation is they may all read clinically normal.
Hmm.
We may just have a patient who's transitioning into perimenopause, where in luteal phase, her estrogen is still 80% of the normal range, and maybe progesterone now peaks at about 30% of the normal range.
Hmm.
So, where both of those are clinically normal values,
The
the,
ratio isn't.
the ratio isn't normal. Maybe they experience more significant troughs at those low points. So, PMS can be subtle in that regards, where the hormones may technically be normal, um, but the ratios get off, and that's kind of where the cyclic abnormalities come into typically that pair with it. So when we look at where does traditional PMS come from a symptom standpoint? Okay, well, estrogen is endometrial proliferative. Progesterone thins and regulates the growth of endometrium, and ultimately causes the endometrium to slough off when it drops. So I would say, if those are out of balance, right, the endometrium is just going to kind of grow like wildfire, which your body really only gets to handle one of three ways. You can have a longer period, you can have more frequent periods, or you can have heavier periods. Or if you're really lucky, you get a combination of all three of those simultaneously. Um, and then we get into the mood aspect. All of your hormones are neurochemically active, right?
Mhm.
So estrogen can influence things like serotonin. It also influences glutamate, which is a neurotransmitter I don't think gets talked about a lot. It's actually our most abundant nervous system excitatory chemical. So while serotonin has positive influence on mood, obviously glutamate can make us a little agitated. And then progesterone in I don't want to say a normal patient, but in a non-PMDD patient interacts with GABA. And GABA is the one neurotransmitter we have that is kind of exclusively, its only job is basically to calm us down. What
Mhm.
helps us sleep, it turns on the parasympathetic version of our nervous system, which is what calms us down. So it's really easy when we talk about neurochemical interaction in terms of PMS to say, okay, well, my estrogen's dipping and falling, and my progesterone's rising and falling. I'm getting all these transient changes in GABA and serotonin and glutamate. Of course, we're going to feel all over the place, right?
Yes,
Yep.
and the symptoms can be varied from acne to not sleeping well to irritability to, like, you name it.
Yep. And the irritability and the poor sleep almost tend to run hand in hand. Those, in
Mhm.
fact, I would say that outside of cycle abnormalities, the poor sleep tends to be the one that I see is mentioned the most.
Mhm. Mhm.
Right.
Some people have like warning shots of cramps, things like that too.
Yeah. And I think with that, PMS in its true form and PMS, not PMDD in that regards, I don't want to say management is simple, but it's not overly
It's not as
complicated.
nuanced.
It's not as nuanced, right? Because then it may be, hey, we need to use a small dose of non-neuroendocrine suppressive progesterone, which means a dose that's not enough to shut that down, right? To
Right.
shut down the communication loop between the brain, pituitary, and ovaries.
Just riding along.
Just right along and kind of fill in the gaps and correct the ratios.
And that could just be in the second half of the cycle. It could be cycling the entire time, depending on what you're seeing in the follicular phase.
Yeah.
Just kind of depends.
Or even a straight maintenance dose to just help fill in the gaps. So,
Hmm.
but in that regards, with a lot of PMS patients, simply correcting that imbalance or supplementing a little bit. Later in perimenopause, we may need to add some supplemental estrogen as well. But for most early phase PMS patients, that may be all it takes.
Hmm.
That may be all it takes. PMDD is kind of its own separate monster where a lot of times that intervention almost seems counterproductive.
Which, let's talk traditional medicine first. I think that that would be a good place to start because, I mean, TikTok is trending with PMDD, right?
Yeah.
Everybody's talking about the like what they experience as well as what their doctors have tried and whether or not it works.
Yeah.
So, the first one is an anti-anxiety or an antidepressant. Seems to be a pretty common response.
Hmm.
Um like you obviously will see some people are seeing benefit from that. Depending on what your symptoms are through PMDD, I could see how that would be beneficial. I don't necessarily think it's correcting the issue, but at least it's sorting some of those symptoms out. And then you're also seeing using an antihistamine,
Right.
which is interesting,
It is.
right? Because normally we're talking about hormones, right?
Right.
But no.
Yeah. So eh, the antidepressants, the most common class of it, most of the antidepressant drugs are serotonergic in nature, which means they're going to generally regulate serotonin reuptake. Those are your Zolofts, your Prozacs, um, citalopram, um, or SNRIs like Effexor or Prestique that regulate serotonin at low levels, but at high doses also hit norepinephrine. And they're reuptake inhibitors, which essentially what that means is it regulates how long your brain lets them hang out on neurotransmitters and the rate at which we recycle neurotransmitters. And serotonin specifically can be helpful regulating that, especially in regions of the brain like the prefrontal cortex that control our more like executive decision making and our rational mindset and things like that. Norepinephrine, although it sounds counterintuitive because that's adrenaline, and you
Mhm.
would think, influencing adrenaline may make it negative, but we need to
Especially if you're experiencing rage.
yeah, but we need to understand with those drugs, they're not necessarily quantifiably raising it all the time. They're just regulating the reuptake and recycling of it so it can stabilize those. So that may be beneficial, and some patients see benefit with it. The downfall, to psychoactive drugs is one, there's a lot of trial and error that goes into it. You're seeing more things like gene site testing and different testing now that are predictive in nature based on a patient's genetic characteristics as far as which drugs they may or may not respond well to, which helps
Mhm.
because up until those tests, it was kind of a crapshoot.
Mhm.
And what's weird about the SSRIs, is you may have 3 drugs that act on serotonin at the same receptor that elicit 3 completely different responses, even though the mechanism of the action is the same,
Mhm.
right?
Mhm.
Um, the other part is those drugs don't come absent of consequence, right? A lot of patients, when they start centrally active drugs, whether it's a SSRI, SNRI, um, uh, uh, one of your anxiolytics like buspirone that works on serotonin and dopamine, but like partial agonists, um, it takes a while to get on them. It can take 2, 4, 6, sometimes 8 weeks to actually evaluate therapeutic response. And for a lot of patients, they do subjectively make symptoms worse before they make them better. So, that can be a real struggle with somebody who's titrating on them is, am I getting worse because of this drug? Or is this the necessary acclimation process to this drug? Will it ever help? You can spend 3 months on the wrong drug and say, well, it takes that long to titrate on and titrate off of it. I've known some physicians in the past that will be like, we're going to start this SSRI, but to, combat the agitation and the poor sleep you may get initially, we're also going to put you on a low dose of a benzodiazepine just for the first 30 days as needed, which then you're getting into drugs where, concerns regarding addictionology becomes very real and prevalent. And there's no guaranteed efficacy. Plus, the other side effects that their number one side effect that's most complained about is pretty pronounced sexual dysfunction.
The other concern is that most of these drugs haven't been tested long term on females. So this person's only experiencing these symptoms for only part of the month. So you're going to be experiencing questionable benefit during that duration of time and then not necessarily needed the rest of the time, but you have to be on it long time, like long durations to even see the benefit for that week or two.
Yeah, and they're not things that you can just take intermittently. It's not like you can just take an
Mm-mm.
SSRI for 10 bad days. They don't work that way.
Yeah, they build up in the system. You have to wait, essentially, wait
Yeah.
and see scenario.
Yep. And should you ever choose to come off that drug in the future, they're extremely challenging to come off of. Right.
Mm-hmm.
And
Mm-hmm.
I can say that from experience.
Yeah.
I was on centrally active drugs, obviously not for PMDD. Um,
No?
but from 12 to 34 or 35. And I think it took, the better part of a year for my body to get used to not being on them. So, and I would not say that I'm unequivocally against central active drug administration either. I certainly think there's a time and a place. But my thought is with the PMDD and the more research that we're having now, um, there's better options out there, right?
Especially because the symptoms only arrive for part of the month,
Yeah,
right? Like,
right. And then, the other option we see a lot is birth control,
oh, yeah.
right? Birth
Yep.
control. And the problem with birth control is it's neuroendocrine suppressive. It's
Mm-hmm.
shutting
Mm-hmm.
down your normal hormones and replacing them completely. But we'll also see as we talk about, PMDD in a little bit more detail as far as what research shows now, as far as like the actual pathophysiology that's different um, regarding hormone responses, stabilizing those values with an exogenous birth control may not yield benefit at all. Right.
Correct.
Right.
Besides the fact that then you don't have visible lab values for
Right.
their hormones.
Right. And then the third one you mentioned is antihistamines. And antihistamines are interesting because there's some inference now that the transient fluctuations in estrogen
Mm-hmm.
can cause intermittent histamine spiking. Right.
Which
Which,
it
yeah.
could.
Yeah, which it could. And histamine is inflammatory, right? And
And
it's
where does most of your histamine response source from?
the gut,
Correct.
right? Most of it sources from the gut. So that's why a lot of people are looking at um, like Pepsid and stuff, antihistamines that are local to the gut. And why does that matter? Why does that help mood? Well, we always think of histamine, we think of allergies, right? We think
Mm-hmm.
about, runny eyes and watery nose. And I always tell patients, Yeah, that's histamine related, but that's just a response to inflammation that histamine creates,
Correct.
right?
Mm-hmm.
So there's a lot more research now relative to depressive disorders and mood, where the migration of uh, inflammatory mediators across the blood-brain barrier is a big impact.
Mm-hmm.
Um,
Anxiety disorders also.
right. So that can be histamine, that can be interleukin 1, beta, TNF alpha, like all these inflammatory mediators, if they cross the blood brain, can be nervous system excitatory and create anxiety and depressive related symptoms.
Mm-hmm.
So, in that regards, that actually makes a fair amount of sense,
Mm-hmm.
right?
Mm-hmm.
As far as histamine blockers or antihistamines in that regards. Um, I'd still say it's treating a symptom, right? Which is fine in that regards.
Yeah, if it's helping.
Yeah, if it's helping, I would almost think if you did that, the ones like Benadryl and stuff that actually have the capability to cross the blood-brain barrier may be a little bit more effective
Mm-hmm.
than like your Zyrtex or Allegras and things like that. But
Yeah, small doses, short amount of time.
yeah,
Don't
And,
ruin your brain.
like I say, you don't want to nod yourself out by living on Benadryl for 10 days a month or anything like that. But yeah, I didn't have any symptoms because I slept for 10 days.
Yeah,
But
I was good. I didn't talk to anyone. I slept.
I slept because I was in a Benadryl coma. Right. So maybe not the most long-term option, but certainly makes sense that there'd be some application there.
Absolutely.
Right.
And I think there's a conversation to be had with estrogen clearance and your gut health on mood anyway. So
yeah, the estrobolome and
Mhm.
all the pathways of downstream estrogen metabolism, which is a whole other conversation.
whole other podcast.
Whole
that we'll
other
hit on a
podcast.
different time.
Yeah, whole other conversation. Anyway, so back to PMDD.
Let's talk about the clinical research
The
now.
clinical research
Let's actually go into what we have seen.
Yep. So,
well, do you want to go? Let's talk about a patient first. Okay. So when a patient is coming in, and obviously not all of them are actually clinically diagnosed with PMDD, still fairly nuanced, right? So it's something that you're kind of interacting with on the front end with symptoms.
right,
So what are the most common ones that you see?
with PMDD.
Mm-hmm. Which ones are you like flag concern?
I would say the biggest thing that flags it is to kind of differentiate that diagnosis is the severity of the mental symptoms,
Okay.
right? So it's one thing when a patient tells me, I'm agitated, I'm irritable, I'm snippy,
Mhm.
right? Okay, that's probably PMS.
Yeah.
When a patient says, I spend 10 days beside myself angry,
Mhm.
I can't talk, I can't function, I called a divorce lawyer, I can't be around the kids, I can't go to work, I can't get out of bed, and I'm flying in and out of uncontrollable rage to crippling depression to unmanageable anxiety, and nothing helps it. Okay, that's beyond the scope of what would be considered normal PMS,
Mhm.
right? And with those patients, generally your traditional PMS interventions don't work. In fact, for a lot of them, birth control and traditional PMS interventions actually exacerbate symptoms.
So they probably are going to say things like, yes, I was on birth control. Yes, I've tried an antidepressant. Yes, I've tried whatever.
Yeah, a lot of those patients will say, yeah, I've dealt with this for a while. It's getting worse as I'm getting older. I've been on, 10 different birth controls because of this, and none of them have fit for me. They've all been terrible. I've tried high dose estrogen, low dose estrogen, progesterone only, and none of them worked. I couldn't take them. I was on them for a month, and it just everything got worse when I took them.
So then testing.
Right.
Obviously, we do blood tests.
Right.
This is a patient that you would immediately route into a Dutch test.
Mm-hmm.
And why?
Yep. So the Dutch test we use a lot. Part of with symptoms of anxiety, stress, and things like that, we always want to look at the HPA axis and evaluate, is there an adrenal component to it?
Rule out or rule in.
Rule out, right? But as far as sex hormone metabolism, the next thing we want to look at is how's our body processing hormones downstream? When we look at progesterone, for example, it may have an alpha or a beta metabolite. We know the alpha metabolite is the one that's most interactive with GABA in the brain.
Mm-hmm.
So maybe they have adequate progesterone, but it's a poor processing downstream.
So they aren't experiencing the calming effects of
Right,
GABA.
right. And then when we look at estrogen metabolism, you have your 2, 4, and 16 hydroxy metabolites.
Mhm.
And with there, we're able to evaluate, first phase metabolism of estrogen. So, look at the parent estrogens and then look at what does it turn into downstream.
Mhm.
Then evaluate on those first phases what downstream metabolite is most problematic. So obviously in that regards, we're looking for what would be called your 16 hydroxy metabolites that may be associated with estrogen dominant symptoms. And then we can look at secondary clearance, which is COMT methylation, right? So look at clearance in that regards. And then if we want to evaluate at third phase, which is elimination, then we'd look at the gut. In
Which
that,
even circling back to methylation, so sorry. Mental health can actually pinpoint 2 genes through that methylation process too. So like you can experience different things if you have a gene mutation in methylation. But
right. And there's kind of 2 big ones we look for, and that's an MTHFR and a COMT. MTHFR, where people most know that from is methylation of B vitamins, right?
mhm.
COMT methylation has to do more, they all influence psychological function, but the COMT genes or COMT gene mutation has more to do with secondary estrogen elimination, but it has a lot to do with how our body processes catechols,
Mhm.
dopamine, epinephrine, norepinephrine, the rate that we use, metabolize, and clear them. So the COMT mutations are really prevalent in mental health disorders. So there's carryover in a lot of this stuff.
So just other little flags here
Yeah,
and there that we may take additional looks at. So if they're a low methylator, that would be something that would be like, well, why?
yeah, right. And then we can look into genetic testing and things like that and
Mhm.
cofactor deficiencies that may influence that.
Absolutely.
So the Dutch test is a great place to start. It rules out or confirms if there's an adrenal component.
Mhm.
It looks at
Generally rules in.
generally rules in. Yes. Yeah. HPA axis dysfunction is super
Especially if you've
prevalent.
been moving, like it's a mood disorder, right? So if you're dealing with uncontrollable rage for half of your month, for sure your adrenals are going to suffer at some point.
Yeah, right. And then it looks at sex hormone metabolism. And that's a great place to start because that, at least at a minimum, helps us rule out and or confirm, is this something as simple as a metabolism issue or a clearance issue? Because you and I both know, because gosh, you look at what, 25 sets of labs a day.
Mhm. Mhm.
There are plenty of patients where quantitatively on paper, their hormone values look fine.
I mean, females specifically.
Yeah, where their
It's like
hormone
that.
values look fine on paper, and it's not really a production issue. It's a processing issue. I always say like blood labs are great, but it's kind of looking at like the ingredients to a cake, but it's not showing the finished product. So it's like, yeah, you got all the stuff there like to make a good cake, but whereas the Dutch test actually shows us what comes out on the other end. Because what we're seeing
You need a
excreted,
whole oven and whatnot.
yeah, 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 yeah. What
Gotta
we're
mix the ingredients together.
exactly what we're seeing in the urine excreted as metabolites, we're seeing the end result of processing, right?
Yeah.
So we know that speaks more to, okay, what are we seeing from a tissue exposure standpoint?
Okay. And
Yep.
then from there, let's talk about treatment.
Okay.
Normal cycle is anywhere between 21 to 35 days, and it is consistent.
Yeah.
You're experiencing the same symptoms throughout the same days every month.
Yeah.
And your period starts on or about the same day, plus or minus 3 days.
Yeah. Yeah. So the ballpark average normal is 28 days,
Correct.
but everybody's a little bit different. And if somebody's like, I have a cycle every 30 days, but it's like clockwork, it's like, well, we're not going to mess with
We're
that.
definitely not messing
Not
with
going to
it.
mess with that. So part of that comes into looking at, some of the more research around PMDD that we've seen recently, probably to answer that question. And to understand PMDD from a like we've already talked about what the hormones do neurochemically a little bit, but then we want to talk about parts of the brain and then specifically how they regulate mood. And the 2 parts that we're really going to talk about probably the most are the prefrontal cortex and the amygdala. Okay. And the prefrontal cortex, we'll just say simplistically, is like our higher executive thinking, our rational decision making, our calmer, motivated, rational part of the brain. Okay. And the amygdala is largely involved in flight or fight response. Okay, so that's our panicky, irrational, I don't want to say irrational, but can be irrational part of the brain that's associated with
It's more
fear.
of an automatic response.
That's associated with fear and anxiety. And there's two things that have shown with PMDD. One's starting to be proven. One's a theoretical interaction. Okay. The first one is what are we actually seeing on brain scans? And when I say we, I mean the research community as a whole. We're not in here doing brain scans.
Would be pretty cool if we could.
It would be
though.
cool. Yes. Yeah.
We'll look into that.
How much I was gonna say, how much is an MRI machine?
And does our building actually sustain that?
No. If the building does, the infrastructure and the power does not. The electricity doesn't. I have to turn the whole building off to run the MRI machine. As we're seeing with patients that they may have a smaller than average prefrontal cortex or a less active prefrontal cortex and a overactive or slightly enlarged amygdala, right? So
hence the anxiety, depressive, rage responses.
Right. Because the amygdala is kind of running the show, right?
Mm-hmm.
The other thing, and this is coming out more theoretical in regards, is that patients with PMDD may, and we're seeing that this may be true in practice, may have a paradoxical response to a metabolite of progesterone that's called allopregnenolone, right?
Mm-hmm.
Paradoxical response meaning it does the opposite of what it's supposed to, right? Mm-hmm. So if progesterone normally improves GABA function and uptake, it has deleterious effects on GABA, right?
So this can happen to just more than PMDD patients as well. People can have negative responses to progesterone supplementation.
Right. Yeah. So it's not just, and we do see that.
It just seems to be more detrimental for the PMDD patients specifically.
Right. And we got to think about if they do have that response and you're blunting the effect or having a negative effect on GABA and the patients whose fear center of their brain runs the show more anyway,
nothing is calming them.
Right. It's gonna throw them into a spiral. And then you couple that with transient fluctuations in serotonin and things like that because of estrogen ebb and flow. It's just a recipe for disaster,
mm-hmm,
right?
Mm-hmm.
So whereas traditional PMS, we may find that treating that patient with progesterone cyclically evens out the curve, right? And that resolves symptoms. What we're seeing with some of our PMDD patients is it's almost the opposite,
mm-hmm.
Where we may be using a very minimal dose of progesterone, but only if needed for the sake of regulating a cycle.
And generally it's flat dosing, not cyclic dosing.
Yep. And then maybe even a small dose of a very small dose of estradiol
mm-hmm.
to try to level out the severity of the curvature. Which helps stabilize serotonin.
Mm-hmm.
Okay. The third piece that we've looked into as an alternative to, maybe psychoactive interventions with psych meds is using some more holistic over-the-counter methods, things like your Gabinol or your Copacalm, which, plug in orthomolecular there, but, that contain a sub-pharmaceutical amount of supplemental L-GABA.
Which is what they're missing. So just supplementing the difference.
Yep. So just adding a little baby dose of GABA supplementally.
Maybe just during that period of time, not all the time.
Yep. L-theanine, which is a normal amino acid that's calming, helps with focus, but non-sedating. Maybe, magnesium support and things like that.
Which magnesium 3-and-8 we love because not only does it help with sleep, but it crosses the blood-brain barrier, or at least clinically has been proven to do. Orthomolecular, shout out again.
Yep. So it's got good cognitive benefit to it. But using some of those small things supplementally, to help with calming effects without having sedative effects or having to lean heavily on, psychoactive pharmaceuticals in that regards.
Which we do not prescribe.
No, that's not no.
Definitely not in the realm for Dr. Bainan.
No, that's kind of out of the scope that she wants to swim or live in. So, which is fine with us.
Besides the fact that we would only see fit to do something cyclically anyway, and that's just not how that drug works.
Right. And then, let's say we did see, for example, estrogen methylation was really poor. right? Somebody's methylating less than 50% of the normal population. Then we'd say, okay, well, we know that that's COMT enzyme driven. That COMT enzyme appears to be slow. So if it's slow, maybe we do want to get into genetic testing and we want to actually evaluate what type of gene variants they may or may not have that specifically influences things like MTHFR and COMT enzyme activity, because that's going to dramatically shift not only their mood, but it's going to influence, how their body processes and utilizes catechols, things like adrenaline, right? Because that can be impactful as well.
Absolutely, because some of these patients may be predisposed to other mental health disorders to begin with.
Right. So, and there's iterations of that. There's fast variants, there's slow variants, there's intermediate variants. So knowing what variant you have, and then whether it's fast, slow, intermediate, matters as far as designing supplemental interventions and things like that as well.
Supporting what it's lacking.
Yeah, supporting it, giving the body the right cofactors, because, and you can see with some of these supplements that are super effective, right, and can be very helpful, and we've seen in practice, seeing the whole picture and seeing specifically if there's one of those genetic variants, which, to be clear, is super common, especially in folks with European descent, right?
Like 60%.
Yeah. So 60% of people with European descent have some level of methylation abnormalities because of genetic variants.
Yep.
But you have to know which one, and you have to know, is it fast or slow, because the interventions you would recommend for a fast or slow variant are going to be really different.
And
right?
You can't guess.
Yeah.
Definitely can't guess based on symptoms.
Right. Because it can be, there's crossover subjectively.
Absolutely.
Yep.
So PMDD.
PMDD. Yep. So it's really interesting. It's probably not interesting for the patient. That's one of the things patients like, I didn't sign up to be interesting. I just want to feel better.
Right.
But, with more of the research that's coming out now regarding brain chemistry and brain activity and some of the advanced testing and diagnostics we have available now, there's a lot more treatment options out there now than there probably even was just 5 years ago.
And getting more to the point, right? Not just trial and erroring this and being like, hope this helps. See you later.
Right. Which
you'll find out in 3 to 6 months.
Yeah. Which, when somebody feels that bad.
And I mean, they've been feeling that bad, right? It's not like this is something that just appeared out of nowhere.
Yeah.
Like most of these people have been cycling since 10, 11, 12.
Yeah. And it's like, this always existed. It's just now unmanageable.
Correct.
Right? So this is something somebody's been dealing with for years and years and years.
Which we seem to see the exacerbation of this specifically into perimenopause, because there is just so much more variability that you're experiencing with hormones and a little bit more unpredictability. So that's what they're experiencing, is the unpredictability. Right.
So it's anyway, it's complicated, but there's definitely good interventions out there. So.
Yeah. Any additional questions, you can always leave a message, or you can always reach out to the office. We're here in Grove City, Ohio, and we're here to help.
Yeah, we are. And we work with patients in the state. We work with a lot of patients out of the state, Yeah, we can help anybody just about anywhere. So